We will let people join in and start to get settled in. Okay, I think we should get started. So we give a lot of time to our fantastic presenter. I'm Tashani Alingasakra, one of the generalists here and the director of our Grand Round series. I am really excited to present our speaker today. Before we get started, I'd just like to do our land acknowledgement, which we start all of our Grand Rounds presentations with. We really want to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCS sits upon their home. We are proud to continue their tradition of coming together and growing as a community, and we thank the Ramaytush Ohlone community for their stewardship and support, and look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And if you'd like to learn a little bit more about how we can support and learn more about the Ramaytush Ohlone people, you can see some links here, and they'll be in the chat as well.
And then also my fellowship at UPMC at the University of Pittsburgh. And my fellowship was in reproductive infectious disease. I also at that time got a Master's of Science in Health Services Research from the University of Pittsburgh CTSI. After I finished my fellowship, I was working for about 2.5 years at this hospital system in Pittsburgh called Allegheny Health Network. While I was there, I was the co-director of our perinatal addiction services. So I have, a little bit of exposure to addiction medicine, not probably as much as our ACT team or as Dr. Seidman, who's also in my division. And then since 2021, I've been a member of the ACOG Committee on Ethics, which has been a real privilege, and I really love that I get to do that work. And I joined UCSF in 2024, June last year. So this slide is showing a scheme or sort of a conceptual framework that is much older and I think really deserves some criticism. The HIV language guide from the National Institutes of Allergy and Infectious Disease, NIAID, they really try to avoid sort of blaming language, which I agree with, and use or offer this idea of key populations. So these are populations who studies have shown might experience higher rates of HIV and STI, and that's due to a complex number of structural factors. But those key populations include sex workers, men who have sex with men, people who use injection drugs, and people who are transgender or gender diverse. And this conceptual framework was offered by Steen and al. In their sort of paper called Feasible but Necessary. And they were really arguing for the inclusion of sex workers in trials to understand how to interrupt HIV or STI transmission. And I think even though their goals were in the right place, this picture kind of shows something that I don't necessarily agree with. It says sex workers, clients, and then lower risk partners. And it says clients infect sex workers who infect many other clients. Clients infect regular and casual partners. And then it offers that targeted interventions aim to interrupt this upstream transmission amongst highest risk sexual networks, and good clinical STI services shorten the duration of infectivity and reduce onward transmission. I mean, there's some truth to this. Good clinical STI services do shorten the duration of infectivity and reduce onward transmission. But this idea that, sex workers are the cause or infecting other people really ignores the complex interrelationship between clients and sex workers and sex activity in the general population. So the other thing I think this ignores is that all of these things, these interventions, STI services, they happen inside the healthcare setting. And it somehow removes us as healthcare workers or healthcare professionals having any kind of role or influence in this sort of idea that HIV or STI are ongoing in the world around us. So a lot of what I am doing is trying to untangle us from this older model, remove this idea of blame, and really focus on how we as healthcare professionals can improve our work to really be effective. And so that next bullet I have there is to explain, rather than this idea that sex workers are infecting other people and the cause of all this, which is, not true, let's instead reframe this, that sex workers have incredible expertise on novel prevention efforts, screening recommendations, and communication best practices. And how can we learn from them? How can we learn from our patients on how we can be better and treat these conditions more effectively? Okay. So in terms of the biomedical tools, what we can offer our patients, the most commonly known, I think now, is just oral pre-exposure prophylaxis, which is, the brand name is Truvada, but it's also called FTC TDF, or emtricitabine tenofovir disoproxil fumarate. But Truvada is been known to be pretty effective, and this is a New England Journal of Medicine trial that was published in 2012. It was called Partners Prep, and it showed among 4,000 serodiscordant heterosexual couples that this combination of emtricitabine TDF was more effective than TDF alone, and it had a risk reduction of 75% to reduce the incidence of HIV among this population. So that was really wonderful, and proved that, FTC TDF was going to be effective also in cisgender women, not just in men who have sex with men. The other thing I have here is just a note on this concept called U equals U, and U equals U equals, it stands for undetectable equals untransmissible, and that's, an older trial that really proved that if someone is living with HIV and they have an undetectable viral load, they are very unlikely, probably not ever going to transmit HIV to their sexual partner. So the other really important preventive method is to remember that highly active antiretroviral therapy for people living with HIV is dramatically effective at supporting the person living with HIV and then reducing transmission to other people. And for people who don't, there's lots of, like, a host of problems with cisgender women needing to know or control or have some kind of effect on what their partner is taking, and whether or not they're undetectable. And so oral PrEP is this really wonderful tool for people to really feel confident that they're probably not going to get HIV from sexual activity. The next trial I want to talk about is injectable PrEP. So I think people are pretty familiar with Truvada. I should also mention there's another formulation of oral PrEP called Descovy, and the difference of that one is that it has less renal effects and probably less side effects. But anyway, there's oral pre-exposure prophylaxis, which is Truvada and Descovy, and then there's now injectable PrEP, which is called cabotegravir. So this was a phase 3 randomized double-blind superiority trial. It included HIV negative cisgender women 18 to 45 who were deemed at risk for HIV and who were using long-acting contraception. They were randomized 1-to-1 to injectable cabotegravir versus oral Truvada, TDF FTC. And then they also notably had this oral lead-in where they used the TDF FTC for a little bit and then started the CAB injections. The CAB injections happened every 8 weeks, which is also how you would administer it if you wanted to prescribe CAB. And this was compared to a Truvada group who got daily pills plus placebo injections. So there were about 3,200 women enrolled, and they had only 4 infections of HIV in the CAB group and 36 infections in the Truvada group. So we felt that CAB reduced HIV risk by 88%, which was statistically significant, which is really wonderful to have these number of options, oral Truvada or Descovy, injectable CAB, really great complement of tools for folks. So this is going to be a set of really busy slides, but I mainly just wanted to point out to people that there's this really great resource called the AIDS Education and Training Center, AETC, And if you Google them, they will have really useful, high yield clinical guidance on how you can prescribe oral PrEP or injectable CAB. And I'm just gonna say the highlights, which is that when you start someone on either of these, you really wanna make sure they don't live with HIV at that time. And that's because both of these are gonna be incomplete treatment for HIV. So if you start someone on an incomplete ART regimen, that will increase the chance their HIV will become a resistant strain. So initiation of either of these, you should get an HIV test, and ideally you want to consider getting an RNA. So sometimes people may be in a situation where they are actively having sex with someone who's living with HIV, or maybe they just don't know. And an HIV RNA will capture someone living with HIV in that window period before their antigen antibody test will become positive. You can do both antigen antibody, but you should definitely get the antigen antibody, and then you should also consider the HIV RNA. Some people will also consider retesting about a week or 10 days or 2 weeks after that initial negative test to really feel confident that this person who might be, at a high chance of getting an acute HIV infection is not becoming seropositive. The other thing to do is get STI testing, just because it's good preventive care. It's not a contraindication to starting PrEP or using PrEP. If you have an STI, we should just figure that you have it and then treat it. And then the important thing to know about oral PrEP is that it, especially the Truvada formulation, has an effect on the kidneys. And so you want to get a creatinine. And then for long-term use of Descovy, you might want to get cholesterol and triglycerides as well. The other thing is that, and some of my data has to do with this, there's this one, in the oral group, there's this idea that 1 week after prescribing, you can call to sort of figure out, how did it go getting your prescription? Were you actually able to get the pills? Have you been taking them? And what side effects do you have? Especially with Truvada, people have what's called a startup syndrome. It's about a month of like nausea and headaches that you can treat with like Pepcid and Tylenol for headaches, and and some flatulence, and it goes away with longer term use of oral PrEP. That startup syndrome goes away. And then there's ongoing monitoring. So about 1 month, you're going to get repeat testing, and then in the oral group, there's a little bit more monitoring at the 3-month mark, at the 6-month mark, at the 12-month mark. And in the injectable group, it's just that every 2 months, they're going to show up to your clinic and get that cabotegravir injection, unless they're comfortable self-injecting. Okay. The other thing is that I talked about the follow-up visits every 2 months for cabotegravir. For oral PrEP, it's about every 3 months, in person or telehealth. And then we already talked about monitoring renal function and oral PrEP, lipids with, especially with Descovy. The other thing to mention here is that people who are living with hepatitis B, that's something that I would recommend, using oral PrEP in collaboration with infectious disease colleagues, or with, maybe City Clinic could help, but it's more complicated if they're living with hepatitis B. The last resource I'll kind of point out here is the National Clinician Consultation Center, which is run by UCSF, but it is funded federally. And they're not quite 24/7, but a pretty available group that can answer any questions and kind of help initiate PrEP for people. Okay. So the other reason I'm sort of giving this talk today, I think people are pretty familiar with oral PrEP. People probably know about injectable cabotegravir, even if they haven't prescribed it. But there's this other data that's arisen around prevention of sexually transmitted infections or sexually transmitted diseases, STI or STD, meaning chlamydia, gonorrhea, and syphilis. And prevention of those by using either pre-exposure prophylaxis or post-exposure prophylaxis with doxycycline. A lot of the data around all of these preventive tools comes from trials conducted with men who have sex with men. And there is limited data for cisgender women and transgender men, which is a lot of the patients we were taking care of. And there's a lot to say about the paucity of research in cisgender women and how that affects, our nation's health, the world's health. And I certainly believe in data for women. And so far, this is what we have. So for doxycycline as pre-exposure prophylaxis in cisgender women, there is some data that it's effective. So this trial done in Japan was done with female sex workers in Tokyo. And they were really curious if taking 100 milligrams tablet, like one tablet of doxycycline every day would reduce the incidence of these sexually transmitted infections. And so you can see that the gray bar is before they started doxy prep, and the black bar is after they started doxy prep. So there is a reduction in overall STIs, 10.2% compared to 2.6%. Chlamydia reduced from 20.7% to 5.7%. Gonorrhea reduced from 7.5% to 2.2%. And syphilis went from 2.3% to 0%. So it's very promising data. I will point out that the underlying prevalence is pretty high of chlamydia in 20% of female sex workers, gonorrhea in 7% of female sex workers. So there are concerns about whether or not this is really applicable to a US population or a population that has a lower prevalence of these infections. And doxycycline is contraindicated in pregnancy. So the other concept is doxycycline as post-exposure prophylaxis. And so this is to use 200 milligrams of doxycycline within 72 hours of unprotected sex. This data is not from cisgender women. This is from men who have sex with men and transgender women. This was done by a UCSF researcher, so really proud of San Francisco, of UCSF in particular. And so what they found is that there was, in people who received doxycycline, a reduction of 29% to 10.3%. You can see that in the circled area on this slide in their primary STI endpoints. That's inclusive of all three of their metrics: gonorrhea, chlamydia, and syphilis. So taking 200 milligrams of doxycycline within 72 hours of unprotected sex in men who have sex with men and transgender women seemed to decrease the incidence of gonorrhea, chlamydia, and syphilis. So while that was really useful in those populations, the trial that looked at doxycycline in women was not that helpful. So this was published in 2025, and it was an RCT in Kenya and included 449 women who were 18 to 30 who were taking HIV prep. And then they were also given doxycycline 200 milligrams within 72 hours after condomless sex versus standard care. There was no reduction in STIs, but the big complication here is that the doxycycline was actually only detected in 29% of hair samples. So we think there was really poor adherence. Adherence is a complicated word to use, but people were not taking the medicine. That actually differed from the people's self-reported use of doxycycline. So people were kind of more compelled to say, I'm using this medicine, as compared to what their hair samples showed. So this was pretty disappointing. Doxy prep did not seem to lower STI incidence, but we're not really sure if that's true, because were people even using the medicine? And I think, there's this other really big complication of stigma, especially, I'm not a researcher in Kenya, and I know that some people in the audience probably have done research there or do research there, but what I understand from reading these trials is that taking these pills is really challenging for people because there's a lot of stigma. And, in your family, if you go to the bathroom and you get out a pill bottle, people are asking you, like, why are you taking that? Like, what is that? And there's really severe stigma around living with HIV. So I think that trying to understand how we can meet people where they are, and both to run trials and to offer clinical tools is, really, really essential. But for now, we don't have sufficient data to really recommend the use of doxycycline post-exposure prophylaxis. So that's kind of a big whirlwind summary of the biomedical tools. And I'll just spend the next, 10 minutes talking about my data, and then hopefully we'll have time for questions. So I kind of shared that I really focus on patient-provider communication, and I'm hoping to really work on anti-stigma interventions. So when I was a fellow in Pittsburgh, I remember, I don't know if this experience resonates with people, but you kind of start fellowship and then your mentors are sort of like, okay, like, what do you want to study? And it can feel like a really overwhelming question. But for me, I really reflected on this experience I had as a second year resident. And I remember I was, in triage on a Saturday afternoon, and I was feeling pretty good. Like, oh, I got my intern year under my belt. I think I can handle, a good number of things that come through the door obstetrically. And a patient who was a sex worker came for evaluation. She had just been released from jail. And I remember taking care of her and just feeling like, wow, like I'm not understanding like your life, and I don't know what's going on, and I need to be better. Like there was so much learning for me in that experience, and it really stuck with me. And so, fast forward 3 years later, when I was a first year fellow, I was like, man, I really want to understand how to serve this community of sex workers better. And so when I was a fellow, I got a little bit of money from our sort of training grant, and I conducted this study, which ultimately became this publication in BMC Public Health. And I'll share some data from the study later that isn't really just focused on PrEP, but this article
Yeah,
really.
it's hard for me to wrap my mind around.
Oh, sorry. I was excited. Maybe someone had a question. Sounds good. So this study really focused on HIV profile, the findings of that study in terms of PrEP. So what I had done was a community partnered study. So I think maybe people have heard that phrase of no studies about us without us, which is really this activist idea that if you're going to do research with sex workers, you have to partner with them, you have to do it with them. So this was a community partnered study. The interview guide, recruitment materials, data analysis was all done with community partners in the sex work community and with sex workers themselves, who are all compensated for their time. And I'm going to kind of move a little quickly through this just so we can get to the results. But people were given, I conducted these one-on-one interviews with folks, and then I used thematic analysis. I had 22 participants total. The median age was 26.5. And then the most participants identified as Black. So 15 of the folks identified as Black. And then there were a few people who identified as gender diverse as well. Okay. So the 4 themes that we identified was that 1, appreciation of HIV risk and prevention strategies grew from information accumulated over time. So sex workers were kind of describing, like, when we start this work, or when I started this work, I really was just like doing it and then didn't really understand necessarily some of the consequent, like, risks that I might get an infection, and that would really be troublesome for me. And that over their exposure in the years, they were like, okay, now I understand, and these are the things that I need to do to be safe at work, be safe at my job, essentially. 2, that PrEP information came from a variety of sources with mixed messages and uncertain credibility. So people described just this really heterogeneous, kind of confusing experience about getting advice from other sex workers, from friends, from like the internet, from social media, and just feeling like, okay, I don't really know what to believe or who to believe. 3, that decision-making about use of PrEP was relative to other behavioral decisions regarding exchange sex. And I think, so what people were kind of describing was like, I have this complex set of priorities in my life, whether that's taking care of my kids or dealing with my rent bills. And if I'm using PrEP, that takes time out of my life. It sometimes costs money. And I'm going to be weighing that against all of these other complex decisions that I'm making at any one time. And I thought it was really meaningful for me, because sometimes I think when we're talking to a patient, we think we're just here, just like take this thing, it's going to be really helpful for you. And we have to remember that people are really taking that information in this broader context of their whole lives, where they have a lot of competing priorities for their time and attention, which is very relatable. I think I certainly feel that way too. And then the fourth theme, that the multi-step process of obtaining PrEP presented multiple potential barriers. So people talked about how, I have to find a clinic. I don't know if that clinic is going to be sex worker safe. And then I have to, get there on time. I might be rejected if I'm not on time. And then I have to get the prescription, somehow convince this doctor to give it to me. And then I have to go to the pharmacy and then hope that it's in stock and then I can get it. And then I've got to take it every day. And that whole arc is just really complicated. And at any point, people could have an interruption or lose access. And then this is a quote from a patient who kind of explains just kind of the power that our behavior has in terms of people coming to care. So this sex worker described, I had an encounter with a nurse because I had gone for an HIV test. I told her I'm a sex worker. Immediately, she assumed that I am HIV positive, and she didn't ask me why I'm there. She just told me I'm going to have to get on the ART. And that person said, I felt her assumption affected me. She just assumed rather than asking me. And they kind of went on to explain it was pretty negative for them, and it made them really hesitant to come back into care in the future. So that experience, that study, and getting the opportunity to really hear from all these really wonderful participants, who I'm really grateful to them for being willing to talk to me, led me to conduct this other study where people were sort of saying, I'm really worried when I go to the pharmacy that the medicine's not going to be there. So I did a simulated patient caller study. We called 481 pharmacies between Pennsylvania and Georgia, to see, hey, if you call the pharmacist to say, hi, I'm a patient. If I wanted to pick up PrEP today, could I get it? We just wanted to see if it was even stocked or if you could get it. And unfortunately, it's pretty hard to get. So in this table, you can see that only 30% of pharmacies had PrEP available, and only 10% had PEP available for same-day pickup. So kind of 7 out of 10 times, people are going to go to try and get PrEP, Truvada, and it won't be there. And they'll have to call ahead or go back the next day. The other thing we found is that rural counties had a lot harder time compared to urban counties, and that ending HIV epidemic status jurisdictions had PrEP, but it wasn't as high as we hoped. So ending HIV epidemic is like a designation that may be going away, but hopefully will persist. And it's supposed to orient more enhanced HIV prevention resources to specific states. In specific regions. So for example, like Philadelphia is an EHE region, Atlanta, San Francisco, Oakland, and that kind of orients resources for folks. So even in these ending HIV epidemic places, PrEP was only available in 56% of pharmacies. So about half the time, even in an EHE region, people weren't able to get it from the pharmacy on the same day. And then I'm just going to skip this slide for the interest of time. So yeah, summarizing all of this, it seemed to me like, wow, there's this problem with the medicine not being available in the pharmacies. And I was sort of wondering, how do I tackle that? And what do I do about that? But there was also this interesting experience where the simulated patients in that study experienced a lot of stigma when they were speaking to the pharmacist on the phone. I just started getting really interested in, okay, how do we communicate effectively to help people achieve their goals, or, try and do the best medicine we can do. And then this is just kind of a funny idea of communication from our field. A medical student yesterday, when she heard that I was giving grand rounds, told me I should include one joke. So here's my one joke. It says, my gynecologist follows me on Instagram. I really do not know what else he wants to see. I think that we can agree following our patients on Instagram is probably not an effective communication strategy, but hopefully there are others that our data can show us. So this is the unpublished data from my simulated patient caller study, where the simulated patients were really, it was one undergraduate student, a couple medical students, and a pharmacy student calling to these pharmacies in Pennsylvania and Georgia. And their script would just say like, hi, I'm hoping to pick up PrEP today, would it be available? And there was multiple points during the conversation where the simulated patients felt like, wow, this is a lot of judgment. So related to PrEP itself, a simulated patient commented that the pharmacist told them, are you kidding? Who uses that stuff? Or that they asked the simulated patient, what is this, what disease is this for? And then it seemed like they were typing and they like looked it up. And then the pharmacist said, oh no, we don't carry anything like that. Another area of stigma was around gender. So all of the simulated patients had a female presenting voice. And so one simulated patient said that the pharmacist assumed they were a woman and then asked if they were on birth control, sort of making the assumption that if you're taking PrEP, I guess you can't have children or you shouldn't ever get pregnant. And then another time, the pharmacist pretty explicitly told the simulated caller, PrEP is not for women. And then it related to sexual behavior. The simulated patient said the pharmacist asked if they had a partner with HIV. The simulated patient felt judged, like they were asking why they were taking PrEP. And I'm just noticing the time. I'm sorry to be just going on and on. So I really quickly want to just go back to my one-on-one interviews with sex workers. And so this is unpublished data, but people had a lot of great ideas to combat this sort of stigma. They were saying like instead of this, I'll just read this quote from one sex worker. So instead of just boom, here, I'm going to give you this. Okay, blood pressure is high, blah, blah, blah. Okay. What about your mental health? What about your safety? Ask them questions. How are you living? How do you feel today? Have you had a knife put to your neck in the last 72 hours? Have you used drugs and felt shameful for doing it? Ask questions like that. Don't ask questions like sometimes, often. You know what I mean? Have a drug addict write a health questionnaire for infectious disease. Have somebody in that situation, not somebody that reads it out of a textbook, because you don't know that life. So your questions are going to be corny and dumb, and nobody's going to want to sit there and answer them. So I think this person was really just trying to say to us, like our words matter. And when we use them, we have to be really cautious about judging people and understanding that they have a lot going on for them and having that kind of empathy and sensitivity to be aware. And importantly, to include people who are dealing with addiction or who are sex workers in the provision of healthcare services. Okay. So I'm going to skip this slide and just sort of mention the K-23 that's brand new for me, called Improving Personalized Communication. I'm on pharmacy staff caring for PrEP seekers, development and pilot of an anti-stigma intervention using implementation science. In this K-23, what I'm really hoping to do is to talk to folks, both pharmacy staff and people in key populations, and try and understand what's going on to perpetuate that stigma in pharmacy services, and then use this principles of person-centered care to construct an anti-stigma intervention so we can, hopefully soften or make more effective the conversations pharmacy staff are having with people who are seeking PrEP. And just to summarize the idea of patient-centered care, which I think people are really familiar with, that encourages the active collaboration and shared decision-making between patients, families, and providers to design and manage a customized and comprehensive care plan. And then person-centered care is inclusive of patient-centered care, but it expands beyond patient-centered care and considering the entirety of a person seeking healthcare. This is just one of my favorite books. And just to sort of name the concept that it might be really radical to do anti-stigma work, but I think people deserve it. So in summary, the clinical pearls are that for use with cisgender women and transgender men, oral Truvada is great to prevent HIV. Oral Descovy is probably better for people who are having anal intercourse. I want to mention that Descovy is not FDA approved in cisgender women, but unless the asterisks, they're having anal intercourse as their exposure risk. And there are some cost concerns that it may not be covered by insurance. And then injectable cabotegravir is better for folks to use to prevent HIV if they are trying to avoid pills and if they seem to have kidney issues. And then in terms of doxycycline for PrEP. It may be effective, but questionable utility given the low comparative prevalence of STI here in the States. And then doxy post-exposure prophylaxis doesn't seem to work, but there was really low adherence. But it does seem to work in people who are men who have sex with men or transgender women. And then in conclusion, that person-centered care is really important and really great. Sorry, I was really rushing at the end there, but thanks so much everyone for listening. And then as Tushani mentioned, this is my new baby who's now 5 months old, and my husband and my son.
Thank you so much, Yasaswi. This was just such an excellent presentation, and it was so wonderful to hear it from kind of your perspective and your journey with really important clinical information, but also about the really important work about how we get these medications to our patients. I want to make sure just open up the forum here to anyone with questions on our Zoom. If you can do a couple of things, either put it in the chat and I can read out loud, or even better, you can unmute and ask questions. I'm bad at the pause. Everyone always tells me that. So I'm going to wait before I ask my question, just a few more seconds. Okay, well, I would love to hear, Yasaswi, in your transition here to San Francisco, what have you noticed in terms of, tell us a little bit about what you've learned about our population here in San Francisco and beyond. What have you, in terms of, where you're coming from, where a lot of your studies have been done, but also I'm just really interested in about the messaging and how we're getting our patients these medications and counseling in our own patient population in San Francisco.
Yeah, it's such a good question. I would say that I've actually been just really impressed with San Francisco and kind of the robustness of city services. I think that there's always room for improvement, but to have things like City Clinic, or to have, like, I think there's like a really robust network of public health nurses that I know that when I'm in Team Lilly and people are having multiple points of contact, it's incredibly helpful. And I think there's kind of a more awareness from patients about PrEP. I often felt like in Pittsburgh, when I kind of talked to people about it, they would give me like this real like taken aback idea, like even though offering it to people would make them feel like I was judging them, which there's some really great data from New Orleans, especially from an OBGYN about how to integrate, like what words can we use to integrate offering PrEP into clinics. And I think it really differs geographically and by situation and by patient, because like, yeah, like to broach the idea, I remember people would often say something like, why do you think that I need that? Like, I'm not doing anything dirty or bad. And it was really this delicate balance, because I was trying to say like, I don't think so either. And maybe you have a partner who's incarcerated, or maybe you don't know what your partner is doing, which is common for a lot of people. And here's this great and amazing thing that might stop you from getting HIV. And I think you deserve to know about it, which is ultimately how I would have those conversations, or really use kind of a strengths-based counseling. But here, I feel like in San Francisco, times I've brought it up, people are a little more thoughtful, and some people have often heard about it before. So that's been a really amazing thing. And I wonder, I don't know for sure, but I wonder if it has to do with the robustness of our allied health professionals and the city services here.
I have a follow-up question there. Thank you so much for that insight, SSW. And I'd love for you to, as a follow-up, to kind of tell us a little bit more about our resources, about City Clinic, which I think a lot of people on this call would benefit to hear a little bit about, and about Team Lilly. But just before that, Dr. Jackson has in the chat, while waiting for your study, do you have some pearls for talking with patients to help them feel not stigmatized?
Yes. the data around this actually, I'm extrapolating from two really important trials. They're not trials, I guess, but studies. One is from my research mentor that I have to, like, I wish for everyone to hear Judy Chang speak. She's an amazing researcher and a wonderful doctor. She's an OBGYN at University of Pittsburgh who really focused on patient-centered communication and really inspired me in my work as a mentor on my K. When she was a Robert Wood Johnson Fellow, she had done this study kind of asking people who are surviving intimate partner violence, what do you want from your doctors? And that qualitative interviews, they found that they want kind of three really essential things. One, non-judgmental communication. So avoiding terms like you've been hurt or like putting people in a victim position. So instead using strengths-based counseling, like you are coming to clinic today. This is amazing. I am so grateful to you. And this is incredibly hard work to organize your childcare and get on the bus and be in our clinic today, really acknowledging and honoring the incredible work people take to be in our presence when they come in person or even on telehealth. So kind of using non-judgmental, and I would argue strengths-based counseling. The second thing people said is they want a warm handoff. So if they disclose something like, that they want a warm handoff to social work, they don't want to just be sort of shuffled through the system. And then the third is to really honor their autonomy, to not force choices or make people do one thing or the other. And so I really extrapolate that data around intimate partner violence, which I know is a different population, but in lack of some of my current data, sort of extrapolated that to the patients I take care of around infectious risk. The other study, also around intimate partner violence, done by Elizabeth Miller, was done in San Diego when she was a fellow there, looked to understand this issue of screening questionnaires. So like having people disclose intimate partner violence made it harder for them to access services. So they randomized family planning clinics to having usual care with a counselor or having universal offering of these like little cards with a mention of an IPV resource phone number. People who got universal resources were 1.7 times more likely to end an abusive relationship than the people who got usual care. So by combining all this like non-judgmental strengths-based counseling with not forcing disclosure, not demanding someone to say like, hey, do you think you're at risk of HIV? That kind of yes, no question is gonna, I think, put people off. So using open-ended questions, what would you like to protect yourself? Or universally offering, hey, I talk to everybody that I'm taking care of about this medication called PrEP, and it can stop HIV from happening. It's a single daily pill. Your insurance will pay for it. What do you think? And not forcing them to say, I'm at risk for HIV, and then I want this medicine. Just saying, no, I don't need that prescription, or yeah, I think that's great, and I can pick it up. I think those are the things that I have tried, the data that supports them.
That was incredibly helpful, Yasaswi. Could you tell us a little bit about what resources we have in San Francisco, both through Team Lily, but also through our public health programs here in the state?
I am still learning, I'll be honest. It's actually because they're so robust that I feel like I'm still really getting an understanding of all of them. And I also think they change pretty often. So I'm gonna actually pivot back to the National Clinician Consultation Center, because not only are they embedded in San Francisco, but they are also there's like a person being paid essentially to just sit on the phone and answer your questions about how can I prescribe PrEP, what services are available to me. And I wonder if that might be a great first place to start. But I can also ask Dr. Seidman, Nika, and then I can circulate an email if people would find that helpful.
That would be amazing.
Yeah.
Well, I think we don't have any other questions in the chat, and otherwise we will let you go. Yasaswi, thank you so much for this presentation. Like I said, it was so exciting to hear about your work, but also just this really incredibly important and helpful clinical reminder to all of us who practice OBGYN and take care of patients, that this is something that we really need to be up to date on and that we need to be more thoughtful about. So thank you so much.